Okay, so I shouldn't look.
So when you get down to the lab today, you need to get that saw. And you'll need to cut through the ribs and cut over. And don't just bury the thing to the hub. You know, just cut through the ribs. The saw doesn't cut through tissue that well, so you'll need to go back with a scalpel and cut through the intercostals. You know, once you've identified them according to the thing. All right. Now this slide right here, one of the things they show you, they name the the pleural surface. If it's next to if it sits on the diaphragm, they call it the diaphragmatic pleura versus the costal, the mediastinum. Mediastinum is anything in the middle. We'll have a talk about the contents of the mediastinum tomorrow morning, but anything in the middle is the mediastinum. I don't really care that you know that, but you do need to know this term here. The cupula is the top of the apex up here. The apex of the lung is covered by the cupula pleura. Okay? In this illustration here, the thing you need to appreciate is there are certain areas in the chest cavity, within the chest cavity, where the lung doesn't occupy the entire chest cavity. Particularly around the back here, the pleura, remember, sits all the way down on the diaphragm, but the lung doesn't go all the way to the diaphragm. There's a space here, that's the pleural cavity. And this space here, where you don't have lung tissue, now remember that lung tissue is covered over by visceral pleura. So in other words, in certain areas, what you have are parietal pleura and parietal pleura in contact or close to each other without visceral pleura between them. You didn't understand what I'm talking about? All right, so here's the lung, this pink thing, and here's the pleura down here. If we go back to this illustration, you see how the parietal pleura goes down to this point and then back up the other side? We have parietal pleura adjacent to parietal pleura without any visceral pleura between them. That's called a recess. You have 4 recesses. The 2 most prominent ones are on your back. So your diaphragm goes all the way out to T12 in the back. But your lung stops at T10. There's a space there. 2 intercostal spaces, actually, where there's no lung. That's called the costodiaphragmatic recess. There's one on each side. And they're prevalent in the back. They do wrap around the side a little bit, but they're really obvious in the back. So when you get in there in your cadaver, you stick your hand behind the lung and you push it way down there. And you realize you're past the lung. There's no lung down here. That's the recess. There are 2 more recesses. If this person is lying down in front of the lung and in front of the heart, there's 2 little recesses here where there's no lung tissue. These are called the costomediastinal recesses. They're where the pleura wraps around the front of the heart, but the lung doesn't. I don't think there's really much clinical significance of that unless you're dealing with tumor enlarging into that area. You'll probably never hear that word again. You will hear this word, though, here, costodiaphragmatic recess. Here are a couple of, let's see, let me turn the light off. So what I want you to see here is that if you look at the left and the right diaphragmatic surfaces, and you call them hemidiaphragms, you'll notice that the the right hemidiaphragm, and you view chest x-rays as if you're looking at the patient. So if I'm looking at you, this is your right side, that's your left side. So if you'll notice that the right hemidiaphragm is higher than the left. And that's because on the right side, the liver is pushing it up. On the left side, the heart is pushing it down. They come down to an angle. That's the recess out here. This would be the recess out here. All right. The other thing you need to pay attention to is that the first rib, remember, it comes out perpendicular and then has its angle and starts slanting down. That means that the cupula is right here. From the anterior aspect, the parietal pleura, or the pleural cavity, goes up higher than the first rib. So if I touch you right here, under your clavicle, that's where your pleural cavity is. The reason that's important is because if you are putting a central line in, or sticking a needle into the subclavian vein, which is right here, that's where if you mess up, the thing you're going to do is drop a lung. You're going to stick that needle into the pleural cavity, releasing that negative pressure, and the lung will collapse. That's one of the complications of putting a central line in. PAs put central lines in all day long. I mean, some PAs do. We don't do it over at the health clinic here on campus, but if you're a hospitalist, yeah, that's true. So understand, going back down to the bottom side here, if you're standing up and you've got fluid outside the lungs, where is it going to go? It's going to go in the costodiaphragmatic recess. And that's what this shows. Yes, ma'am.
Is the difference between the height of the right and left part of the diaphragm generally that extreme? Like, is that the norm?
No, that's the norm. That's the norm. Yeah. And on a lateral view here, remember you're looking at both 3 dimensions squished into 2. This would be which hemidiaphragm is that? That's the left hemidiaphragm. That's the right. You can see the full length of the right hemidiaphragm right there, because remember it's higher. The reason you can't see the left only to right there is because the heart sits here. You lose the diaphragm muscle and the heart muscle. It has the same density. So the right hemidiaphragm looks like it's only half the length of the chest. And in fact, it's all the way across. You just can't discern it from the heart. All right, now in this example here, what we have are some pleural effusions. There's no pleural effusion on the left, but there is on the right. You see that the diaphragm, the angle, is called the costodiaphragmatic, we'll just call it the recess, is blunted. The angle is blunted. That's because fluid is in there. Over here on this side, you got so much fluid in there, you got a meniscus all the way up here to the top. There's so much fluid in there, it's almost filled up or around the lung on the left side. I got a question for you. How do you know the fluid is around the lung and not in the lung? It will look the same on a chest x-ray, almost. How do you know it's around the lung and not in the lung? Well, if it was in the lung, you wouldn't get a meniscus. Okay? The other thing is that when you do a lateral decubitus, you put them on their side, it's called a lateral decubitus. If it's around the lung, it will pool in the bottom. If it's in the lung, it would still be up in the lung. The easier way to do it, though, is to get a CT scan. Over here on this side, it's around the lung. It's pooled at the back. Over here on this one, it's in the lung. This is an infiltrate. This is like pneumonia, where that's a pleural effusion. Pleural effusion. if you're gonna tap that pleural effusion, where do you stick the needle? At the top of a rib, superior surface of the rib. This is the pneumothorax. What we've done is we took a knife wound to the chest, released that negative pressure, and the lung, because of its elasticity, collapsed. Here's the lung all collapsed up near the mediastinum. You'll notice out in here, there are no vascular markings from the lung. Parenchyma. Parenchyma is the general tissue or the stroma of an organ. The reason you see these little fiber things here, that's not airway, that's blood in vessels. That's what the lung markings is, because of blood in the vessels. You should be able to follow these vessels all the way out to within a centimeter of the lateral chest wall. Over here, there are no markings. This is a pneumothorax. Pneumo, air in the thorax. A simple pneumothorax is just when you poke a hole in the chest wall. If I were to take a knife and just stick you in the chest wall, not really far, just enough to poke a hole into the parietal pleura, release the pressure, your lung collapse. Another way to do it is to poke a hole in the visceral pleura. You understand? If I poke a hole in the visceral pleura, the lung will still collapse because the negative pressure goes away through your mouth. You follow me? Say, if you don't follow me, raise your hand. You don't follow? Okay. So, if so I can release that negative pressure by poking a hole there. Or, because then it equilibrates with the outside. Or, I can poke a hole there. And it will equilibrate through my mouth. People with emphysema, they have blebs on their lungs. They grow blebs on their lungs, which is like a big vesicle. No, not a vesicle, it's an air cyst. Then when they rupture, that's what happens. They'll often have a simple pneumothorax because of these ruptured visceral pleura blebs. Tall, thin high school athletes, mostly basketball players, in vigorous exercise, running up and down the court, they for some reason have spots on their lungs that will pop, and they wind up with little simple pneumothoraces all the time. You know, you get one or two every year. High school basketball player, short of breath, comes in and says, "Oh, just can't catch my breath." You get a chest X-ray, you've dropped a lung. Well, part of the lung, usually, not a whole lung. Okay, normal. You frequently see it with tall, thin male athletes. I don't know why.
Is it something you can see? Because I know one of our cadaver died of emphysema. Like, could we see the blebs, or are they too small?
No, you can't see them. I mean, you can on a CT or MRI, but you know, you're not going to see them on a plain X-ray. You just assume if you have some 60-year-old emphysemic guy comes in that's having trouble, sudden shortness of breath, get a chest X-ray and look for that collapse, okay, pneumothorax. Now these are characteristics of a simple pneumothorax. You're going to have decreased breath sounds because you have decreased lung in the area, that's obvious. You're going to have respiratory distress because you're not oxygenating as well. The mediastinum will shift to the pneumo side. So if I drop this lung over here, I've got all this new space, my mediastinum is going to shift that way. There's your mediastinum right here. So you would see a shift of your trachea towards the side of the decreased breath sounds. And because you have all this increased space here, the diaphragm, the dome of the diaphragm will accentuate. So instead of its normal arch like that, it will arch way up like that. So on a chest X-ray, you'll see a big exaggerated arch of the diaphragm, of the hemidiaphragm. Okay? That's a simple pneumothorax. This is a tension pneumothorax. And a tension pneumothorax, what happens here is these are due to trauma. Like you fall off a roof or you hit a steering wheel in an accident. What happens there is that you don't have a hole in the pleura. You don't have a nice hole in the pleura. What you have is a tear of the visceral pleura. The visceral pleura tears because of the trauma, the blunt force trauma to the chest. Every time you breathe in, air escapes through that flap. When you breathe out, the flap closes, trapping the air in the pleural space. You take your next breath in, you get more air, the flap closes, trapping that air. What you eventually wind up with every breath is more air in the pleural cavity under tension. It's under pressure. You follow me? Because it's under pressure, it does a couple of things. One is the mechanism of injury you need to pay attention to. I hit the steering wheel in a car wreck. Or I was put in the roof, the shingles on the roof, and I fell off the roof. But I can't breathe. You know, I've decreased respiratory distress. Decrease in breath sounds, respiratory distress. Here, though, the mediastinum will shift away from the side of the pneumothorax because the pressure is going to push everything that way. So if I've got decreased breath sound over here, I look at my trachea and it's sitting over here, I have to think tension pneumo. The reason this is bad is because you have all these great vessels of the heart right here, namely the superior vena cava. This tension in the mediastinal shift puts pressure on the superior vena cava. You have decreased venous return to the heart. If you have decreased venous return, you're going to have decreased cardiac output. If less is going in, the same less is going to come out. Therefore, what you wind up with is a falling blood pressure. The blood pressure is going to decrease the bigger and bigger this tension gets. Until finally, you've got a heart sitting there beating, but the blood is not going anywhere. It's completely, it's empty. Right? So if the heart is not producing any cardiac output, you're not going to have a pulse. Although the heart, electrically, will look like it's beating. That's called pulseless electrical activity. If I put you on a monitor, and I see, you've got a good heartbeat, I mean, everything looks absolutely normal, and you have no pulse and are unresponsive, you have PEA. A tension pneumothorax is a cause of PEA. There are 8 causes, this is one of them. There are at least 8 causes, this is one of them. A significant one because it's associated with trauma. The other thing about tension pneumo is that because it's under pressure, it pushes the dome of the diaphragm down. If you'll see right here, look where the dome of the diaphragm is. It's going down. It's not exaggerated like a simple pneumothorax. It's pushed it down. The way you fix that is you stick a chest tube in. Usually the lateral 5th intercostal space here, there's a chest tube. You'll wind up putting chest tubes in. Very brutal thing to do to somebody, but you can see the chest tube going in right there. It's got a little radio opaque stripe inside the tube itself, so it shows up on an x-ray. but there's the tube going into the chest cavity. You hook the tube up to a water lock and put it on suction. So you put it against the wall on suction, and it sucks out it restores the negative pressure of the chest. I should say it that way. So that's chest tube. In a tension pneumothorax, if you suspect a tension pneumothorax, if you come into the emergency room and you have all those characteristics of a tension pneumothorax, what I'm going to do is I'm going to tell you that this is going to hurt a little bit. I'm going to identify the second intercostal space at the midclavicular line. And we all know how to do that now. And I'm going to stick a needle in your chest to decompress the tension. If I said, well, you know, I don't really know what's going on here, so I'm going to send you down to X-ray. By the time you get back from X-ray, you'll be in PEA and dead. So if you have a mediastinal shift away from the side of the decreased breath sounds, falling blood pressure with an increasing pulse, because your pulse is trying to compensate for it, you better do a needle decompression. Otherwise, you're going to wind up with a dead patient. Now, if you don't have those things, with the blood pressure problems, you got time to send them on down to the chest to get a chest X-ray, or have the mobile unit come to you. But if you suspect a tension pneumo, needle decompression of the chest, also referred to as darting of the chest.
Is there an average time span that would happen as far as your pulse going down? Like say they were in your office, the nurse took vitals and their pulse was this, and then you suspected that, could you do it again? Is it going to drop significantly or pretty quickly?
Yes, it drops very fast. Once it starts falling, it goes very fast. With every breath, you're putting more and more pressure on that venous return to your heart. And that's why it's a standard of care to dart the chest and not wait for an X-ray. The respiratory tree, the trachea, yes sir.
Don't you run the risk of, so when you do that, you decompress the chest, don't you eventually now have the needle going into the visceral pleura?
It may, but what you're going to do is when you needle decompress the chest, your next step is to put a chest tube in. So if it pokes through the visceral pleura, who cares? You're going to put a chest tube in anyway. You can't do a needle decompression by itself. Actually, probably what's going to happen is they're going to go to the OR.
Do they do the chest tube without the needle decompression?
Oh yeah,
Okay.
yeah.
Yes.
If you wind up having a pneumothorax, for a gunshot wound or a stab wound, you're going to stick a chest tube in.
Is there any other condition that would cause the mediastinum to shift that you should be aware of before sticking the needle there?
Is there any other reason?
Yeah.
No, not really. Okay. The respiratory tree itself starts at the bottom of the carina. The trachea descends and bifurcates at the angle of Louis. Therefore, your trachea is only this long. The trachea is only that long. When it bifurcates into two main bronchi, or primary bronchi, I don't care what you call them. Some people will call them main stem bronchi. The thing you need to be aware of is that the right main bronchus is shorter, fatter, and more in line with the trachea than the left. So if you swallow an M&M or a Skittle, where is it going to go? It's going to go in the right. 99.99% of the time, it'll be in the right. The primary bronchi branch into lobar bronchi. You have 5 lobes of the lungs. You have 3 on the right, 2 on the left. We'll cover that in just a second. So you have 5 lobar bronchi. 3 on the right, 2 on the left. The lobar bronchi divide into tertiary bronchi, and there are 10 tertiary bronchi on the right, 10 tertiary bronchi on the left. You don't need to memorize the names of the tertiary bronchi. Each one of them has a specific name. It goes to a specific segment of the lung. Note that the tracheal rings are not rings, they're C-shaped. They are down in the primary bronchi as well. But then once you get into the lobar and tertiary bronchi, they become plates of cartilage. They're not ring-shaped, they're plates of cartilage. The cartilage right here at the bifurcation of the trachea is called the carina. Know that term forever, carina. The carina, understand, looks like a pair of tighty-whitey underwear. You got the big trachea coming in the top, and then the two primary bronchi going off on the side. When you do it bronchoscopy or endoscopy, and you're coming in from the top, and you see that carina, you'll think, first time you see that, you'll say, oh, that does look like tighty-whitey underwear. That's what I've always thought. There is a branch of the pulmonary artery that supplies the lung. There's 10 branches on the right, 10 branches on the left. That sounds a lot like the tertiary bronchi, right? So, a bronchopulmonary segment is an area of lung that's supplied by a tertiary bronchus and a branch of the pulmonary artery. It's on the slide. A okay. Because of that, a chest surgeon can go in and actually remove a segment of a lobe rather than having to remove the entire lobe if they have to. Although most of the time they just remove the entire lobe or the entire lung for that matter, especially in the case of cancer. There's one stupid anatomical thing that I'm not sure you'll ever need to know this, but I threw it in there just in case. All right, so here's the main bronchus going down. Here's one lobar bronchus. Here's the other one. There's the middle lobe right there. The pulmonary trunk comes out of the heart and divides into a right and left pulmonary artery. Remember that it's blue here because the pulmonary artery contains deoxygenated blood. So you have a right and left pulmonary artery. All of the lobar bronchi are below the pulmonary artery, except the bronchus going into the right superior lobe. That's called the eparterial bronchus. You can actually see it on a lateral chest x-ray. The eparterial bronchus. That's the only lobar bronchus that's above the pulmonary artery. Okay, the features of the lungs. And what you'll do today in lab is you'll take off the chest plate, look at that, ooh and ah, the chest plate, and then you're going to reach in there and you're going to remove the lungs. We'll take the lungs out of the cadavers today, okay? And these are the things, what you're going to be left with is a mediastinum and two empty cavities. All right, the features of the lung, you'll have fissures, first of all. You'll have two oblique fissures, and then on the right side, you'll have a horizontal or transverse fissure. That divides the lung into the 5 lobes, 3 on the right, 2 on the left. The visceral pleura, understand, goes into the fissures. So you can pull them apart. You can pull the fissures, the lobes of the lung apart. Now your lungs are going to be embalmed, inflated, so you'll have something to work with. On the left lung, you have a space here, or a notch, where the heart sits. That's called a cardiac notch. And because you have that notch, it produces this tongue-like protrusion here of the left upper lobe. It's called the lingula. So you need to appreciate the similarities and differences between the two lungs. The left lung has an oblique fissure and a lingula and a notch. The right lobe has a horizontal or transverse fissure that the left one doesn't have. It too has an oblique fissure. So similarities and differences between the two lungs. If you look on the mediastinal surface of the lungs, this is the root of the lung right here, the hilum. This is where everything goes in and out. If you make your cuts just perfect, you'll have one primary bronchus, you'll have one pulmonary artery, and you have two pulmonary veins that come back from each lung. You will not make a perfect cut. You will have a whole bunch of holes that you're going to know what the hell is going on here. All right, this is the way to tell the difference. Touch them. If you touch it, remember you've got plates of cartilage in the bronchi. So you're gonna feel that you'll be able to identify it. Oh, that's the bronchus. It may have already split into the lobar, so you'll have two of them. The artery, the pulmonary artery, coming from the heart into the lungs, carrying deoxygenated blood, is an artery. The wall is thick. It's muscular. The pulmonary veins coming back are very thin wall, paper thin veins. Easy to tell apart. Okay? The other thing is that the pulmonary arteries do not supply the lung tissue itself with oxygenated blood because it's deoxygenated, right? You have branches that come off of the aorta called the bronchiolar arteries and veins. Now, the lung is 99.99% air. There's really not a lot of tissue there. It's going to look like a lot of tissue because it's a fluid, embalming fluid-filled bag right now. But in reality, there's almost nothing to a lung. Therefore, when you get in there and you look at the mediastinum, you're going to have the bronchus, the pulmonary artery, two pulmonary veins, and the bronchiolar arteries will be in the hilum somewhere, and they will be relative to the size of these, that big. Very tiny. Nonetheless, if you remove a lung, you have to identify them and tie them off, or you'll bleed to death. Now, remember I said that when the trachea divided into the two bronchi, it went in at an angle? When it did, remember, this thing is covered by visceral pleura, right? When it went in there at that angle, it produces this pleat right there. That's called the pulmonary ligament. There's one on each lung. It extends inferiorly from the hilum. And what it is at the hilum, that's where the visceral pleura is coming around to become parietal pleura, right? But because it goes in at an angle, it produces this pleat of the connection between the visceral and the parietal pleura. That pleat is the pulmonary ligament. When you open the chest cavity up, stick your hand down there and you'll feel the hilum up here, and you run your finger inferiorly. You can't just go under the hilum. It has to track down a little ways and then go under that pleat. That's called the pulmonary ligament. The lymphatics of the lung tissue drain towards the hilum. Lung cancers are spread through the lymphatics, not through the blood. So you're looking for enlarged lymph nodes in lung cancer. Here are some examples of lung cancers. Over on your right, this is called a coin lesion. It looks like a coin, a quarter. That's all it looks like, a coin. That's what it looks like on a CT. That's lung cancer. If it progresses unchecked, that thing is going to get bigger and bigger, and you're going to wind up with This is the normal mediastinum up here. You're gonna wind up with a widened mediastinum due to the presence of these enlarged lymph nodes full of cancerous cells. Whenever you hear the words widened mediastinum, that's usually not a good sign of anything. Unless you're a little child and it's your thymus gland. A little thymus gland is a lymphatic structure that's present when you're born, and it goes away by the time you're a teenager or so. When you look at chest x-rays of little kids, they have a widened mediastinum. That's because of the presence of the thymus gland. And you have no thymus gland. It just turns to fat as you get older. If I go back to that, I probably have to go way back. Let me just go way back. You really can't appreciate it. But you can see the pneumothorax in this kid. Anyway, right in here is where you'll see the thymus. You can't see it because the heart has shifted over here because of the tension pneumo. Sorry, I forgot to explain that. The autonomics of the heart and lungs, very simple. They are. Parasympathetics, the vagus nerves. The vagus nerves will descend into through the neck, through the toilet sheath, we know that. They enter the inlet of the thorax. The left vagus will travel anterior to the arch of the aorta. The arch of the aorta. The right vagus travels over the subclavian artery. You'll find these in lab today. You'll also find, particularly on the left vagus, right there is a connection, an embryological connection to the pulmonary trunk, and I'll talk about this more tomorrow, called the pulmonary ligament. There's a nerve that comes off of the vagus that goes underneath the arch of the aorta. That's the recurrent laryngeal nerve. You can find it in lab today. No, I think it's tomorrow you find it when we do the heart. Where the vagus is headed will be visceral efferent pericardia at, on, near, or within the organ itself. So if we're talking about the heart and lungs, the cardiac ganglia sitting right here on the underneath the arch of the aorta. So you've got the preganglionics come from cranial nerve 10, the brainstem, synapse on the postganglionics right here. From there they go to the lungs, or the trachea more specifically, the airways, not the lung tissue themselves, or to the heart. Okay? The sympathetics are just as simple. The preganglionics arise from T1 to L2 in the lateral horn, come out, synapse in the sympathetic chain, and from there the postganglionics just go straight to the heart, into the trachea. Very simple. So the cardiac ganglia are functionally part of the parasympathetics. The sympathetics might run through it, but they don't synapse in it. They've synapsed in the chain ganglia. You put them together, and this is what it looks like. You have branches that come off of the vagus. You have branches that come off of the sympathetic chain going into this ganglionated plexus. What they do here, particularly in relation to the respiratory system, is we've kind of been over this. The parasympathetics decrease the diameter of the airways, thinking that if you're doing the fight or flight, the sympathetics, if the parasympathetics decrease, the sympathetics would increase. So if you're fighting or flighting, you want to move air. You want to dilate your trachea, right, in your primary bronchi. Right. So parasympathetics also increase glandular secretion, where sympathetics decrease glandular secretions. We know that, because that's what happens almost everywhere. So in treating asthma, which is a decrease of your airway diameter plus increased secretions, what we want to do is we want to stimulate the sympathetics. We want to give them a sympathomimetic. We want to mimic the sympathetics. That will dilate the airways and decrease secretions. Albuterol, Proventil, Ventolin, there are a whole bunch of different brand names. That's what it does. It's a sympathomimetic. Also makes you jittery. Yeah, it makes you jittery because it's stimulating the sympathetics. To decrease the secretions, what you want to do is you want to block the parasympathetics. So you use a parasympatholytic. The lytic, you block the parasympathetics, like Atrovent. That's why asthmatics are on albuterol and Atrovent. A lot of them. Now, the thing you don't want to do with an asthmatic is you don't want to block sympathetic tone. If you block sympathetic tone, that means the parasympathetics would dominate. You'd wind up with a constricted trachea and secretions. That's why you don't give an asthmatic a beta blocker for their hypertension. Beta blocker is a type of drug that blocks sympathetics. A beta blocker can cause an asthma exacerbation. Any questions? Yes, ma'am.
So, on the commercials, they'll say like, this is a long-term asthmatic treatment, not a short-term like an inhaler. What is the long-term use?
A rescue inhaler, or who in here's got asthma? You have albuterol and Proventil in your purse or pocket, and that's what it does. It stimulates, it dilates the, it's a rescue inhaler that when you start getting wheezy, you take a couple of hits, it dilates your vessel, your trachea, right? It's a short-acting inhaler. There's a group of these drugs that's called a long-acting type of this medicine, that if you just use it alone, it can increase death in asthma, because a long-acting beta agonist is what this is not a rescue inhaler. That's why they tell you to avoid those in asthma exacerbations. They're good for maintenance, but they're bad for rescue. Okay? Go to lab. So tomorrow morning we'll start